This presentation is on manual therapy for the elbow. This presentation is a review for the lab on manual therapy for the elbow. It is meant to prepare you to spend lab time on the actual techniques that we will demonstrate during class time. In this presentation, we will review the muscular anatomy that is most commonly treated around the elbow with stretching, as well as deep transverse frictions. We will also go through an explanation of the classification and arthrokinematics of the joints that comprise the elbow and the joint mobilizations that are used in treatment of restrictions of the elbow. The elbow is a common source of pain in the upper extremity, particularly in those that do a lot of work with their hands or spend a significant amount of time on the computer. Many people do not stretch their upper extremity in the same way that they do the lower, and therefore muscular tightness is a problem around the elbow. The other contributing factor is that the flexors and extensors insert into common origins, so there is a lot of force pulling through that insertion with activities of the upper extremity. The muscles that we tend to focus on are the wrist flexors and extensors, but you can also stretch supinator and extensor pollicis longus, among others. Just a quick review of the anatomy of these muscles. Again, remember that the detail that you learned in anatomy class is important for some things, but for stretching you need to focus on the general origin and insertion of the muscles. With flexor carpi ulnaris, this is the common flexor origin to the pisiform. The muscle creates wrist flexion and radial deviation. With manual therapy, in addition to knowing your origin and insertion of the muscles, you need to remember your surface anatomy. I have included pictures of the surface anatomy to assist with landmarking tissue when you are working through your lab. Remember that manual therapy is about feel. I can give you the theory and demonstrate it in lab, but in order to get good at this, you need to practice and pay attention to what you are feeling as you do the techniques. Therefore, surface anatomy is very important. Flexor carpi radialis runs from the common flexor origin to the bases of the second and third metacarpals. It creates flexion at the wrist and radial deviation. Here is a diagram of the surface anatomy of this muscle to help with landmarking. We will often stretch the wrist flexors as a group, so often it is not necessary to differentiate between flexor carpi radialis and flexor carpi ulnaris, but there may be instances that you will want to try to isolate each muscle. This information will come from your patient history, what the patient complains of, and the daily activities or movements that produce symptoms. Also with your assessment, you may find that one muscle is more at fault or the cause of the problems, more so than another, and you may choose to treat each muscle independently. The next group of muscles that we will go over are the wrist extensors. The wrist extensors again are often treated as a group, but there are instances that you will isolate them. Extensor carpi radialis brevis runs from the anterolateral epicondyle of the humerus, essentially the common extensor tendon, down to the dorsal base of the third metacarpal. Along with extensor carpi radialis longus, it extends and radial deviates the wrist. This picture is just a review of the surface anatomy of extensor carpi radialis brevis. Working together with extensor carpi radialis brevis, longus works to extend and radially deviate the wrist. Its origin is not the common extensor origin, as it starts at the lateral supracondylar ridge of the humerus above the common extensor origin. It inserts into the second metacarpal. The origin of this muscle is important when we come to deep transverse frictions around the elbow, as the angle that you will friction it is a different angle than those that originate at the common extensor origin. And here is a picture of the surface anatomy of extensor carpi radialis longus, and as you can see, it inserts higher up on the humerus than with brevis. The last of the wrist extensors that we will go through in this presentation is extensor carpi ulnaris, originating at the common extensor origin and inserting into the fifth metacarpal. It extends and creates ulnar deviation of the wrist. As with the flexors, The extensors are often treated as a group, but it is important to know how to differentiate these muscles, as it may be helpful in your treatment. And as you can see in this diagram, the extensor carpi ulnaris starts at the lateral epicondyle, but it crosses over to the other side of the wrist. Frictions commonly performed around the elbow include the common flexor origin, the common extensor origin, extensor carpi radialis longus, the ulnar collateral ligament, and the radial collateral ligament. Due to the fact of the number of muscles that attach to the common extensor origin, it is a common cause of dysfunction and pain around the elbow. It is the soft tissue at fault in tennis elbow or lateral epicondylitis. In order to appropriately friction the common extensor origin, you need to friction across the tendinous tissue. This will be demonstrated in class. Remember that when frictioning a tendon, you want to put the tissue on slight stretch, so therefore you will friction the common extensor origin with the elbow extended. The difference with extensor carpi radialis longus is that since it inserts above the lateral epicondyle, in order to friction this effectively, you need to friction in the direction parallel to the length of the humerus to be perpendicular to the insertion of the muscle. So the red arrow in this picture will show the direction of friction for extensor carpi radialis longus. The common flexor origin is a common source of pain at the medial epicondyle and is commonly treated with deep transverse frictions. As with the common extensor origin, when you treat this tendinous tissue with a DTF, you put the tissue on stretch, which in this case again is elbow extension. This picture shows the surface anatomy of the common flexor origin. So as you can see, it's a fairly localized spot, and this is often a place that patients complain of pain, and we use a friction to treat that. The ulnar collateral ligament is an extracapsular ligament taut throughout range of motion. The anterior is taut in extension, posterior in flexion. Overall, the ligament is taut in the functional range of 20 to 120 degrees and is a primary stabilizer of the medial elbow. Rupture of this results in gross instability at the elbow complex in full extension, which is the closed pack position, and therefore has bony congruency. Because the ulnar collateral ligament has multiple bands, it is often difficult to ensure that you are at right angles to the tissue that you are frictioning. In this case, try to orient yourself with the majority of the fibers, so essentially in the same plane as the elbow joint line. The radial collateral ligament is less commonly injured due to the structure of the elbow and the way the elbow is used. Remember that the supinator muscle originates partly from this ligament's superficial aspect, so if this muscle is a problem, you do need to assess this ligament as well. The annular ligament is not as commonly treated with deep transverse frictions due to its function, and because of its function, it's not a source of pain as frequently. The elbow complex is made up of three joints: the ulnohumeral joint, the radiohumeral joint, and the radioulnar joint. Even though the distal radioulnar joint is not really part of the elbow complex, we will discuss it here as it is functionally related. Over the next few slides, I will go through a review of the types of joints, the joint surfaces, and the corresponding glides that we will use in treatment. The ulnohumeral joint is classified as a compound joint, meaning that there is more than one articulation within the capsule. These include the ulnohumeral joint together with the radiohumeral joint. It is synovial and it is a modified cellar. It has 1 degree of freedom, resulting in flexion and extension. The osteokinematics are flexion with conjunct adduction, meaning the ulnar moves in a medial direction. This allows the hand to bring food towards the mouth. Extension is together with conjunct abduction, resulting in the carrying angle of the elbow. The closed pack position is full extension and supination, with the resting position as 70 degrees of flexion and 10 degrees of supination. The joint surfaces of the ulnohumeral joint are as follows. The ulna is concave on a convex humerus. Therefore, the arthrokinematics for flexion are an anterior glide with a slight lateral glide of the ulna on the humerus, which is sort of a scoop motion due to the coronoid process of the ulna. Extension is created with a posterior glide or scoop with slight medial glide of the ulna on the humerus. These diagrams just show the posterior and anterior glide motions of the ulna on the humerus. Unlike planar joints or ovoid joints, you need to add a bit of a scooping motion to these because of the coronoid process of the ulna. We can do pure distraction of the ulnohumeral joint, and we do that with the elbow joint at a 90-degree angle. This diagram shows the surfaces of the joint and the reasoning behind this. The next joint that is included as part of the elbow joint is the radiohumeral joint. This joint is classified as a compound, synovial, unmodified ovoid joint. It functions as a modified ovoid joint, though, due to the constraint to movement from the annular ligament. It is compound because it is within the same capsule as the ulnohumeral joint. Theoretically, the joint is capable of 3 degrees of motion, but it actually only has 2 due to the annular ligament. The osteokinematics of the radiohumeral joint are flexion, extension, and pronation, supination. The closed pack position is 90 degrees of elbow flexion, with the forearm supinated to 5 degrees. This is important to remember when we start to mobilize the joint. Although we occasionally mobilize the joint in close to 90 degrees of flexion, we need to ensure that we are not in a supinated position. The resting position is full extension and supination. The joint surfaces are a concave radius moving on a convex humerus. The arthrokinematics for flexion is an anterior glide, and extension is a posterior glide. The movement of pronation and supination at the radiohumeral joint is just at end range, as most of this movement actually comes from the proximal radioulnar joint. For pronation, there is a posterior glide of the radius on the humerus at end range, and an anterior glide of the radius on the humerus for supination. The radioulnar joint has 2 components, the proximal or superior radioulnar joint, or abbreviated as PRUJ, and the distal or inferior radioulnar joint, DRUJ. The proximal radioulnar joint is a compound joint as it is still in the same capsule as the rest of the elbow complex. It is synovial, modified ovoid, and functions as a modified cellar due to the annular ligament. There is 1 degree of freedom, which is pronation and supination. The closed pack position is 5 degrees of supination, and the resting position is 35 degrees of supination with 70 degrees of elbow flexion. The axis of forearm motion goes from the head of the radius proximally to the head of the ulna distally. The distal radioulnar joint is a complex, compound, synovial modified ovoid joint. It is complex because of the ulnar disc, or the triangular fibrocartilaginous complex, or TFCC. The osteokinematics of this joint are pronation and supination. The joint shapes for the radioulnar joints are as follows. The proximal radioulnar joint is a convex radial head moving on the stationary concave ulna. The distal radioulnar joint is a concave distal radius on the convex ulna. The arthrokinematics of the proximal radioulnar joint are a anteromedial glide of the radius on the ulna. For supination, it is a posterolateral glide of the radius for pronation. At the distal joint, it is a posterior glide of the radius for supination and a straight anterior glide for pronation. These images demonstrate the reasoning for the posterior and anterior glides associated with pronation and supination at the proximal radioulnar joint. For example, with pronation, the head of the radius will roll in an anterior direction. In order for it not to roll out of the articulation with ulna, it has to have a posterior glide that goes along with that. At the distal joints, it is just a straight posterior or anterior glide because you are now moving the concave surface rather than the convex surface. We will go through a practical session of all of these glides in lab, and just a reminder that in addition to the joint mobilizations at the elbow and forearm, that you can provide manual therapy to a patient through active neurophysiological stretching of the forearm flexors or extensors. You can also apply deep transverse frictions to the structures listed here. Remember from previously in this presentation that the direction of frictioning the common extensor origin and extensor carpi radialis longus will differ due to the difference in orientation of the fibers. We will review this in class. This is a list of the joint mobilizations that we will cover in today's or Tuesday's lab. For the distal radio-ulnar joint, we will do it if we have some time. If not, we will include it as part of the wrist.